No questions asked.
Okay, thanks for the invitation, Dr. Iakovou. Thank the organizing committee. So I would like to present to you a case, our Friday case, with the title An Odyssey of Femoral Penetration. It is from our hospital, of course. It is about an 82-year-old male patient who was referred to us for a heart team evaluation because of severe symptomatic aortic stenosis. He had a medical history of HFrEF, a type 2 diabetes mellitus, severe peripheral arterial disease, and ICD for primary prevention of sudden cardiac death, and dyslipidemia. He was deemed too high risk for surgical approach due to a high Euroscore, and so we proceeded with a TAVI. His transthoracic echocardiography pre-intervention revealed a reduced ejection fraction of 25%, and aortic valve area of 1, and AVA index of 0.6, as we will see later. We can see here the reduced ejection fraction. We can see the jet of the aortic valve stenosis. We can see also the small orifice with a heavily calcified valve. So we proceeded with the screening coro. We saw that the left main had a lesion of 60%, but after FFR and IVUS assessment, we decided not to proceed further, and we did an ostial RCA PCI to proceed further with the TAVI. We see here the CT angiography. Based on these diameters due to the annulus and the LVOT, we chose to a self-expanded Evolut 34 millimeter valve. But what is especially important is that this patient had heavily calcification in the periphery, in the right femoral and iliac vessels, and the abdominal aorta, and as well as in the left femoral vessels. We can also see here that the luminant diameter is 4.7, which is sometimes even inaccessible for an interventional cardiology to advance the 18 French catheter, to advance the delivery system of the valve. So what we did, and we said that based in the multi-center trials here, that we can see that the transfemoral TAVR with a peripheral vessel intervention was superior in terms of MACE, in terms of all-cause mortality, with in comparison with non-transfemoral TAVR. So we proceeded with Shockwave, with IVL, and we will show now the video. So we see first that we did under ultrasonographic guidance the punctures of both femoral vessels, and we advanced in 6 and 9 and 14 French sheaths. I will move a bit forward. Here is the further ultrasonographic, and now we can see that we have already difficulties with the cross-wiring from the left to the right femoral vessels. So we proceeded then with the IVL. We did it initially in the above the inguinal ligament, in the iliac vessels, and as well we did in the femoral vessels, as we will see below. So what we did actually is that we took advantage of the acoustic waves of the IVL to do it in a stepwise fashion. So we started from 2 or 3 atmospheres, and we proceeded up to a maximum of 5 atmospheres just to be sure that we have the integrity of the vessel. We can also see the acoustic waves that it is evident from this picture. And so now we move forward to the video. We can see that we did it below. We did exactly where the 4.9 millimeter we had seen from the CT angiography, the critical stenosis that we had to overcome to advance our catheters. So we tried then to advance the catheter, the delivery system. It was very difficult to advance the 18 French catheter. So we said that we can advance better the 14 sheath, 14 French catheter, to start with the balloon valvulopathy of the valve, and then to move forward again. So we can see here the difficulty that we had to deliver to advance the delivery system. So what we did is that we did an angiography to see exactly where the stenosis was. We see this circumferential stenosis both at the external iliac and at the femoral vessels. So we were forced to do a balloon angioplasty there to undergo the further procedure. And we did a balloon angioplasty with a Mustang 6x40 in this proximal vessel. As well as we will see further, we did it with a 7x40 to also try to overcome the stenosis in the iliac vessels. So with a small effort, we were then finally able to advance the delivery system of the valve through an 18 French catheter, as we will see here. Let us show also the expansion and the delivery of the aortic valve. It was really difficult. We had many hours in the cath lab. So now we see the expansion of the valve. As we said, it is a self-expandable 34 millimeter evolute. We can see we had a successful both implantation and expansion of the valve. We can then see the orthography that confirmed the right position of the valve. And so now we had time to go back then to the femoral vessels to see if we had the integrity of the vessel preserved. We chose with a surgical consultation to proceed to a digital subtraction angiography, which showed a leak there at the proximal. It was near the insertion point, it was near the puncture point. So we had to proceed further with balloon angioplasty. And we can see that the final result was much better. We had a much better picture. The patient was stable. He had no need for receiving red blood cells. And so we can see now the echocardiographic assessment post-TAVI. We had the TAVI in place with normal function, with good gradients. And as we said, it was a patient really difficult. We chose to perform first the IVL, the shock wave with a balloon 5.5 times 60, but we were forced to do also balloon angioplasty. But overall, the patient had the normal hematocrit values, normal neurologic status, and the femoral Doppler afterwards showed no signs of active dissection and no need for femoral reintervention. Thank you for your attention.
Thank you, Sano. Nice. So we have Petros Dardas. Petro, any comment?
Yes, good case and very good demonstration. I would like to ask what was the size of the IVL balloon?
The size was 5.5 times 60.
Well, I think for the iliac it's a small balloon, small IVL balloon. That's why that's the reason that you needed to do PTA after. Usually for the iliacs we use a 7.0 balloon. I don't know.
Yes, I have to agree with that, and this is the after-action review that we did. We were guided by the measurements of the CT. It was on the smaller sides, 4 to 4.5. So
you don't measure the unit diameter.
Yes, we know, but it would to had a lot of negative remodeling. So maybe we're a little bit biased, but as an afterthought, maybe we should have gone directly to the largest balloon.
7.0 is for the iliacs.
Definitely, that's would make it easier, but it was really difficult access. So but it would facilitate it definitely. bigger balloon.
Congratulations, and you're absolutely right. We may face difficult cases, difficult peripheral vascular disease, and we have to use advanced methods to have access to the aortic valve. The only question I have is if you were ready to tackle vascular injuries, more severe vascular injuries. Do you have a surgeon?
Yeah, we had a surgeon in the cath lab.
Of course, we have stents as well, but there was no need to use them.
Yeah, no, but
Yes, we of
you
course,
prefer-
yes, there was a consultation with the surgeon. Okay.
The next case,
Thank you, Lord.
Dr. Georgopoulos has Dr. Katsianos